Our talk today is going to be a systematic approach to bronchiolar disorders. And we're going to be basically dividing it as between 5 different speakers. Myself, my name is Dr. Sujit Cherian. I'm from the University of Texas Health, McGovern Medical School, and I'm an associate professor there. And we have all other speakers who will be speaking on different topics. My topic here is basically going to start with is bronchiolitis and anatomy of small airway diseases. As I said, I'm from the University of Texas Health. I have no disclosures to make with regards to this talk. And the lesson objectives that we will be dealing with as of today with regards to this session here are terminology, definition of bronchiolitis, relevant anatomy of small airways, and classification of bronchiolar disorders. Now, the first question is what is the importance of bronchiolar disorders, and the importance really lies in its confusing terminologies and the different terms which have been applied to classify bronchiolar disorders or to define bronchiolar disorders. So one is it has its confusing terminology. Number 2, there are multiple classifications and not a really uniformly accepted classification. Number 3, symptoms are non-specific or disproportionate to the radiological findings. It has several diverse histopathologic and radiological presentations. And an assessment is difficult because a significant percentage of bronchioles need to be affected before clinically being manifest. So now let's talk about the terminology. So the terms used or synonyms which have been used to describe bronchiolitis or bronchiolar disorders are small airway disorders, bronchiolar disorders, or peripheral airway disorders. By definition, when we talk about small airway disorders, they basically are referred to airways with a diameter of 2 millimeters or less. And to confuse it even further, there are different terms applied for a constricted bronchiolitis, which include obliterated bronchiolitis, include bronchiolitis obliterans, and all of these 3 actually basically refer to the same entity. On the other hand, there are similar terms, but they have different meanings. One is, and the classic of this is bronchiolitis obliterans and bronchiolitis obliterans syndrome, and they both actually mean 2 different things. While the pathology might be the same, the bronchiolitis obliterans, as we all know, refer to the syndrome seen after transplant and basically secondary to a constricted bronchiolar process going on. So in this way, you can see how the terminologies are different. There are several terms and some similar terms, but different meanings. So this all adds to the confusion with regards to bronchiolitis or bronchiolar disorders. Now, what is the definition of bronchiolitis, right? Bronchiolitis refers to inflammation and or fibrosis involving airways smaller than 2 millimeters in diameter, and they often lack a cartilaginous wall, and this also includes inflammation of the alveolar ducts. Now, what is to remember is when you take the airways starting from the trachea all the way to the alveoli, there are 2 raised to 23 generations from the trachea all the way to the alveoli. And when we talk about small airways, basically it means the generation starting from 2 raised to 8. And these are the membranous bronchioles, and as we said, purely conducting. And this goes down all the way to the terminal bronchioles, which is the last unit of the airway without the alveoli, and the respiratory bronchioles, which is around the generation of around 2 raised to 17-ish or so. And these communicate directly with the alveolar ducts and are in the range of 0.05 millimeters or less. So anything 2 millimeters or less basically refer to the small airways, and these are at the 2 raised to 8th generation of the airways. Now, bronchioles have ciliated cell lining epithelium, and they become progressively flatter as it moves down to the terminal bronchioles, respiratory bronchioles, and further so on. And the bronchioles are, along with the pulmonary artery branches and lymphatics, have a connective tissue scaffolding, and these are basically located in the centrilobular zone. Okay? Now, when I talk about the secondary pulmonary lobule, or basically the most basic unit on a chest CT scan, as we are seeing here, this is basically the smallest measurement is usually between 1 to 2.5 centimeters. And what is there inside, as we discussed, is the bronchiole, which is accompanied by the pulmonary artery and the lymphatics. And the lymphatics basically move along the septa, along the periphery, and into this corner zones where it drains into the venules and to the right side of the heart. So this, and this we will be alluding more when we talk about the radiological presentations in bronchiolar disorders. But the centrilobular zone is where the bronchioles are located, and on the CAT scan it basically manifests as pathology, mainly concentrating in the centrilobular area. And as far as pathogenesis is concerned, there is initially a stimulus which causes damage to the bronchiolar epithelium. What later results is further inflammatory process, and it results in either repair and resolution versus recovery, versus scarring with collagen deposition, and then the clinical manifestations of bronchiolitis results. And so of particular importance is that smaller airways are vulnerable because the particles get deposited there with the narrow lumen, and that makes them very susceptible to the obstruction. Okay. Now, as we said, with the relevant anatomy, the pulmonary acinus is defined as the lung unit distal to the terminal bronchiole. The acini measures 6 to 10 millimeters, and as defined by Miller, as we mentioned before, secondary pulmonary lobule refers to the smallest unit of the lung marginated by the connective tissue, and measures 1 to 2.5 centimeter. And this also is referred to as the silent zone. Basically, the bronchioles are also referred to as the silent zone of the lung because a significant amount of bronchioles must be affected before the disease usually presents in the absence of any other coexisting diseases. And this is of the order of around 75% of the bronchioles. Okay? And radiological imaging, as we said, will get to the level of the terminal bronchioles, but not to the level of the respiratory bronchioles and beyond that. So my first question here for our audience is, bronchioles contribute a significant percentage of airflow resistance within the lung. Is this statement true or false? Good. The majority thinks it is true, but that is not the right answer. So the bronchioles, so it is good that we are doing this lecture here. So the bronchioles typically contribute only 10% of the airflow resistance. The majority of the resistance really is provided by the larger airways, unless there is a significant amount of bronchioles get affected, and then they contribute to the airflow resistance. So the statement here is that does it contribute to a significant proportion of airflow resistance? The statement is not true. Okay. So as we said now, as we talk about the anatomy, there's the large airways and the small airways. The way they are different is that the bronchioles do not have cartilage. They do not have the goblet cells which produce mucus. The cross-sectional area, because of just how diffusely they are, or it is much greater, which results in, because of the increased cross-sectional area, decreased velocity, and then that translates to a laminar flow. Okay? And the resistance really is, because it is the cross-sectional area is very high, is really very low. So basically, as I said, only 10% of the resistance within the lung is provided by is secondary to the bronchioles, to airflow. And the cells, as we said, there are no goblet cells which produce mucus, and as we get to the bronchioles, what happens is the cells which produce surfactants and the cells which produce other substances such as the club cells, or previously referred to as the Clara cells, get more and more predominant. Okay, and this is what we mentioned before. As we said here, the bronchi are typically the first to 3 generations. Bronchioles are 4 to 13, and when we say small airways, typically it means from the 8th generation onwards. Okay. So this is again basically a histological section here showing TB, which is a terminal bronchiole. Respiratory bronchiole, as you can see, is partially covered by the ciliator, and it communicates with the alveolar spaces. And this is along with the pulmonary artery, and this is this connective tissue which keeps it together. So this is different pathologies of how these different diseases can cause bronchiolitis. And as you can see, the pathology is different, and this will be dealt with in a different lecture by Dr. Callahan. And we will be talking about the different bronchiolitis here. And as you can see, the pathology differs here in each of these cases here. So now let's talk about the classification. And when we talk about the classification, there are several classifications which have been used for bronchiolitis. One is there is a clinical classification of bronchiolitis. A second is a histopathological classification of bronchiolitis. And as you can see on the left side, this is a clinical classification. Second is a histopathological classification. Then there is another classification which causes it as secondary classification and a primary classification, which is primary bronchiolar disorders versus secondary bronchiolar disorders. But this is using other secondary causes for bronchiolitis. Okay? And yet another classification is bronchiolitis as a primary bronchiolar disorder and a secondary bronchiolar disorder. And primary means where the pathology is basically at the level of bronchioles and not associated with any other diseases. And secondary bronchiolar disorders there is ILD, interstitial lung diseases with bronchiolar involvement, versus large airway diseases with bronchiolar involvement. Okay? And for the rest of our lecture today, we are going to be using this classification, where we will have one of our speakers talk on primary bronchiolar disorders. One of the other speakers will be talking on ILD with bronchiolar involvement, and then large airway disease with bronchiolar involvement. And this is the classification scheme that we are going to go ahead with. Okay? Now, this is the second question that I have. And the question is, this is the most common form of bronchiolitis encountered in adults. A, constricted bronchiolitis. B, if you want to read it out, it's this, but I'm going to just say dip neck. C, infectious bronchiolitis. D, respiratory bronchiolitis. And E, diffuse panbronchiolitis. Well, good. Well, we have basically between two choices, and respiratory bronchiolitis is the most common answer, is the right answer here. And we'll be talking about this in the next few presentations. Thank you very much. Now I'm going to invite Dr. Megan Conroy, who will be talking about the physiological basis and radiology relevant to bronchiolar disorders. Thank you.
All right, thank you, Dr. Cherian. As you mentioned, I was tasked to discuss the physiologic and radiographic features of small airways diseases. I'm an assistant professor at The Ohio State University in Columbus, Ohio, and I have nothing to disclose. And so, as Dr. Cherian mentioned, the bronchioles, due to their relatively very large cross-sectional space in comparison to the bronchi, contribute very little to airways resistance, with the exception of at very low lung volumes. As you approach residual volume, these unsupported small airways may collapse. And so this presents a diagnostic challenge. If they are contributing very little to the airways resistance, then our typical pulmonary function testing is not likely to capture particularly early disease. And so we do need to see very significant amount of disease throughout the lung before we're getting clinical symptoms, before it's becoming apparent, and even further more advanced disease before we're seeing changes on PFTs. So what may we see? We may see some relatively subjective changes of a late scooping of the expiratory limb of a flow volume curve. I've heard quoted this decrease in maximal mid-expiratory flows, or this MMEF 2575. That's probably, though, of lower predictive value and is probably quoted more often than it is of use. You can see some change in the waveform that you derive from a single breath nitrogen washout test. So that phase 3, that alveolar phase, the emptying of the alveoli. Due to the heterogeneity of disease affecting these very small airways, the oxygen washout in the beginning of this test is not going to equilibrate very equally across these diseased lung units. And so those with high resistance in those diseased bronchioles will have higher amounts of nitrogen present, and therefore in that alveolar emptying phase, you'll get an increase in the slope with more nitrogen emptying out later on as those diseased lung units empty. And lastly, with very advanced disease, looking at lung volumes, you may see an increase in residual volume. So these are relatively nonspecific, not very easy to find early disease, so certainly interest to find a test that may help us both in more accurate and earlier diagnosis. Fortunately, most of these still exist within the research realm than they are available at your friendly neighborhood PFT lab. We can talk through some of them still. So the first is impulse oscillometry. This is an effort-independent modality that's based upon a forced oscillation technique. So here you have a patient who is passively tidal breathing, and pulmonary mechanics are determined by superimposing small external pressure signals on tidal breathing. And that's accomplished by a loudspeaker generating harmonic waves at a fixed frequency through a conduit tube onto the mouthpiece and into the respiratory tract of that patient. Then pressure and flow transducers measure amplitude and phase differences to determine the impedance of the respiratory system. And from that, reactance and resistance is then derived. So these higher frequencies are going to reflect back off the larger airways, and lower frequencies are going to go deeper down into the smaller airways of the lungs. And so here you can see some resistance patterns changing, the difference between resistance at 5 hertz and 20 hertz, giving a clue towards small airways disease. There are also patterns of changes in resonance and reactance that you can see as denoted by the red arrows here. And there is data to suggest that this can give us early disease detection of small airways disease with these abnormalities. This is largely done, again, in research settings, and the majority of the data on this exists in particularly pediatric asthma. You can imagine having a patient only needing to tidal breathe without doing complex maneuvers of having to follow those has a lot of value in that population. Another metric that might be a little bit easier to understand is a lung clearance index. And this is taking from a multiple breath inert gas washout test. The concept here, again, this heterogeneity of disease in these small airways is going to result in some lung units being less effective at that gas equilibration. And so if we're looking at how many breaths, how many FRC turnovers it's taking for equilibration of that inert gas out of the lungs, if you have more diseased small airways, it will take more turnovers of FRC before you have full equilibration of that inert gas, and that will increase this lung clearance index. And this lung clearance index has demonstrated great sensitivity in detecting early airways disease, still largely done within research settings, but a little bit potentially easier to be available within your local labs. Moving into radiographic changes that we will see in small airways diseases, predominant that we will see is really on expiratory imaging, a mosaic attenuation. And so this you may be familiar with shows increased attenuation or gray change to that pulmonary window, reflecting normal lung emptying, and a darker area of relatively decreased attenuation reflecting air trapping. And so some examples here from single cuts through high resolution chest CTs. This is a patient of a 75-year-old with asthma. On the left, we have an inspiratory cut, and on the right, we have an expiratory cut. And I hope this projects adequately, that you can see that there is some heterogeneity, but air trapping present on that expiratory film. To show you more than just a single shot through this, got some animations coming through the pulmonary windows here. You can see largely normal pulmonary parenchyma. This patient also has an incidental finding of a very large hiatal hernia. And on the expiratory images, which I will show again, we see a significant worsening of this change in mosaic attenuation present throughout. Looking at another disease state, this was a 51-year-old patient at my center, underwent a double lung transplant a year and a half prior to these CTs. On the inspiratory images, you can see really largely normal pulmonary parenchyma, maybe with a few areas that have some hinting towards potential for air trapping, and really marked worsening on expiratory images. Similarly, to show you a little bit more view through these lungs, pretty good looking pulmonary parenchyma present here. We've got some significant worsening, this mosaic attenuation present. on expiratory images. Lastly, another process, a 48-year-old who underwent stem cell transplant for myelodysplastic syndrome 1 year ago. And on the left of this inspiratory image, you can see some hint towards some potential mosaicism that is significantly more pronounced in the expiratory images. Superimposed, this patient also has some fine nodular changes, probably a improving inflammatory or infectious process. Again, here on the inspiratory images, you do see some of that mosaicism. And on expiratory phase of high-resolution chest CT, marked worsening of that. So considering this, for each of these patients, none had obstruction on PFTs. For our transplant patients, they did start to see some decrease in their FEV1. And this patient here actually still had a normal residual volume despite this expiratory phase, though it was starting to increase. It was still within limits of normal by NHANES data set. There are some research ongoing and products being developed that computer software to quantify the amount of mosaic attenuation present on chest CT that may be another non-invasive and early modality for diagnosis of these diseases. So in summary, our pulmonary function testing will often remain normal, and you may find only subtle changes in our typical widely available forms of pulmonary function testing in these diseases. There are some more sensitive tests of impulse oscillometry and lung clearance index that are not readily available, but do show good promise in the ability to find this. And you can find air trapping accentuated on expiratory images of high-resolution chest CT to provide radiographic evidence of this disease.
Thank you, Megan. We have next Dr. Sean Callahan, who will be talking about primary bronchiolar disorders.
Hi guys, I'm Sean Callahan. I'm at the University of Utah. Thank you for letting me talk to y'all today. My voice is going after a pretty gnarly cold my daughter gave me 2 weeks ago, so I apologize if my voice is crackling some. I've been trying to get oscillometry at my center for the last 2 years and failed, so I appreciate the refresher, Megan, but we're still trying. These are my disclosures. I don't think they're relevant to the talk today. So quick overview. This is the way that I think of bronchiolitis. I've found this to be kind of the easiest rubric for classifying these patients. So we're going to focus on the left hand here, which are patients with primary bronchiolar disorders, and leave the interstitial and large airway stuff to other talks. I'm also going to omit diffuse panbronchiolitis because this is an entity that's predominantly seen outside the United States, but you guys are free to read about it at your own leisure. So another big disclaimer, this is probably some of the crappiest outline I've ever written, but I was tasked with going through the specific entities of bronchiolitis, so we're just gonna go through each one of these, so I'm sorry. General disclaimers. As you guys have already heard, we have a big problem with bronchiolitis in that our usual tests are not very good for this. The real reason is our tests are predominantly good at measuring upstream, so the large airways here, this is where PFTs measure, but the disease is down here. By the time that you catch it on PFTs, it's probably already too late. And CT, while it's still probably the best thing that we have in common clinical use, it can be missed still. So this is the preeminent paper that described constricted bronchiolitis in our soldiers returning from the Middle East. And I've highlighted here about 2/3 of patients had a normal CT scan. Now they got biopsy because they were dyspneic or they had like low results on a CPET, so they weren't completely normal, but they had otherwise normal CT scans. One thing I think is really hard about all these is that path isn't very clear cut. One thing I think that we should be aware of, I think most of the people in the room are pulmonary clinicians. The pulmonary field and the pathology field has diverged a little bit in how to approach these. So there has been a bit of a move from pathologists to really simplify how we describe these. This is one example on the left of pathologists describing it as obliterative or constrictive bronchiolitis, follicular bronchiolitis, and diffuse panbronchiolitis, and then saying things fall underneath it and just saying it's these three. I find that really hard as a practicing clinician who sees probably the bulk of our bronchiolitis patients at our university. This is an example from someone I literally saw in clinic 2 weeks ago. This is a mess. So there's dilated bronchioles with interluminal mucus. Could be asthma. There's parabronchiolar giant cells. Sounds like HP. They got subepithelial fibrosis. Sounds like constricted bronchiolitis. They had a few eosinophils in there, which there is this thing as eosinophilic bronchiolitis. And then somewhere in the report, the pathologist said there are a few areas that look like NSIP. Like, what do I do with that? That doesn't fit anywhere in with this. And I would say the majority of my patients that get referred to me for bronchiolitis who've had a biopsy, it looks something like this. Like, this is a very extreme case that I've put up here as the representation, but it looks a lot like this. Our MDD called this patient constrictive bronchiolitis. I thought it was more HP, but in the end, the guy got steroids anyway. But we digress. All right, so moving along, etiologies. Infectious bronchiolitis. Had to give a shout out to my daughters. This is Eliza on the left, Clara on the right. They have both succumbed to bronchiolitis in their short lives. Infectious bronchiolitis is really common, but typically more in kids. And the reason being is we think that the small airways have higher levels of resistance in them. So they just get picked off more easily with these infections. So they can get quite a bit sicker. What are the common infections that cause infectious bronchiolitis? There's a list of them. The most common ones are going to be your flu, RSV, parainfluenza. I'm suspicious that we got parainfluenza because we have myalgias and fevers at home and stuff. And then mycoplasma and H. influenza for bacteria. This is a patient who has bronchiolitis following a viral infection in a kid here on the right. How do you treat this? It's really just supportive care. If you look at the children literature on infectious bronchiolitis, there's a little bit of support with inhaled steroids. If you want to extrapolate that to adults, so be it, and go for it. One thing to note when you look at bronchiolitis with infections, there is a little bit of a distinction on whether we're talking about bronchiolitis in the acute phase. So people get an infection, they get small airways that are inflamed and constricted. But some of these people, small fraction, we don't know how many, but definitely a small fraction, will get fibrotic changes. So on the left is an example of an infection. So you see some plugged airways, some of these nodules, tree and bud opacities. And then on the right is somebody who's scarred down. So the yellow asterisks denote areas of air trapping in a mosaic pattern. Okay, so let's get to the stuff that you guys are going to see more commonly and have to treat primarily as adult physicians. Let's do an audience response question. Which of the following exposures is not associated with constricted bronchiolitis? So Middle East deployment, e-cigarette use, coal mining, diacetyl flavoring, and chlorine. Okay, we have a mix of answers. Most of you got it right, though. So coal mining is the right answer. The rest of these can cause or are associated with constricted bronchiolitis. So constricted bronchiolitis, it has a lot of different names. So when I talk about constricted bronchiolitis, people may have different terms that they're using. People will use the term bronchiolitis obliterans, obliterative bronchiolitis. Some people will say proliferative bronchiolitis. All of that usually means this entity of constricted bronchiolitis. The most common cause of this is what you guys already know, which is allograft recipients, so lung transplant, stem cell transplant. We're not talking about those in this talk. If you're looking at the rest of people who get constricted bronchiolitis, it's a hodgepodge of things. The thing that we think about the most, again, are vets coming back from the Middle East who've been exposed to a fire pit, and that's fire pit here on the right. If you guys haven't heard about this or know what goes into a fire pit, it's a mess. They just throw like human feces and rubber and styrofoam and everything in it. Like, no wonder people get lung disease afterward. So things, inhalational injury like fire pits are a good cause. Post-infectious, all of that accounts for about 20%. And then the rest is like about a third we never realized the cause, a third are autoimmune, like connective tissue disease, inflammatory bowel disease, and then some are paraneoplastic, like dip neck and stuff. I'm not going to go through this. This is more for reference. But this is a common list of exposures that can cause constrictive bronchiolitis. Those of you taking your boards probably need to learn the diacetyl one, the artificial butter flavor. This is the seminal series that showed the popcorn workers who had greater exposures to diacetyl demonstrating lower FEV1 than those with less exposure. The other things practically to be aware of would be Middle East deployment, like I said, and then my personal vendettas against e-cigarette use, so I've included that here too. How do you diagnose this? This is still technically a biopsy-driven diagnosis. Now, that said, in the right context, we do have patients that we say that's probably constrictive bronchiolitis. They have a good exposure. They have connective tissue disease and compatible imaging. But if you don't know what it is, you don't have a clear cause, the imaging looks like it, we still end up submitting these people to biopsy for the most part. Here on the right are some examples of biopsy patterns. So somebody in an acute early phase has a lot of inflammatory cells surrounding their small airways, leading to progressive scarring, like in the middle square, and then eventually the whole airway just kind of obliterates upon itself in severe disease. The PFTs really can be whatever they want to be, as Dr. Conroy had mentioned just a minute ago. How to treat this is really a big shrug. Like, we don't know. We end up extrapolating recommendations from other diseases to this. So remove offending agents, obvious. Immune suppression associated with connective tissue disease. This is where a biopsy is often helpful. So again, where the patient is in terms of process from inflammation to scarring, like how scarred are they versus how inflamed they are. If they're still pretty inflamed, I'll err on the side of immune suppressing those patients, but if it's just straight up scar, I don't bother. Standing macrolides sometimes work for these people, and then low-hanging fruit like pulmonary rehab. I end up referring a lot of these patients to transplantation. Okay, follicular bronchiolitis next. So what is this? Best way to describe this is there's lymph tissue in the lung and it doesn't belong there. You get this hyperplastic lymphoid follicles and these germinal centers like you see here on the right that are causing impingement into the airway. Who gets this? Big ones to remember are going to be patients with immunodeficiencies. They can be an infectious consequence. Really, really common in connective tissue disease. Let's say most of my patients in clinic with follicular bronchiolitis have a connective tissue disease. And then think about chronic inflammatory insult. So every now and then I'll get a consult for follicular bronchiolitis that was seen on a biopsy, and it's like from hypersensitivity pneumonitis. Like it's just a prolonged inflammatory result. These are some CTs of it on the right. You get ground glass opacities. And a very kind of peculiar pattern that I like is something called cotton and bud. So you have tree and bud, and then on the end, instead of the little dots like in regular tree and bud, it looks more fluffy like cotton, like you see here on the right. How do you treat this? It's really treating the underlying condition. So if somebody has HIV, antiretrovirals, CVID, IVIG, connective tissue disease, immune suppression. We'll often give immune suppression, azithromycin, and inhaled steroids a shot in these patients. This tends to be a disease that responds to treatment. So the patients that I have and I give medicine, they tend to do better than the patients that I have with constrictive bronchiolitis. All right. Last audience response question I have for you guys. In patients with uncomplicated respiratory bronchiolitis, what treatment is routinely indicated in addition to smoking cessation? Is it inhaled steroids, systemic steroids, macrolide therapy, or nothing? Oh, good job, guys. Nothing is the correct answer. Man, I have some trainees who are like, how can you not do anything for these patients? Like, listen, there's pretty good data, like don't do anything. So be mindful, this is a smoker's disease in the vast majority of cases. Now, some people get it as exposure to mineral dust, but that is rare. I have seen some people like that, but usually it's related with cigarettes. This was a great study from back in the 80s that I love to quote to any resident who will listen to me, or back in the 70s, I'm sorry. But it was young people who died just incidentally, like in motor vehicle crashes or something, and they biopsied their lungs. It was found in 100% of people who were smokers. And these are like young people, they're like 20s, 30s. Even though they have it though, the vast majority of people aren't symptomatic. So it's just there, it's a bystander. One quick tangent is, when is it ILD? So I'm an ILD doc, that's typically what I see. It rarely is an ILD. Now that said, people do get fibrotic changes. When they get fibrotic changes, we call that RB-ILD. This nomenclature is kind of hogwash. I think that people should just refer to all this as smoking-related interstitial fibrosis. That's my own sort of grammar Nazi sort of response to all this and trying to get rid of abbreviations. But it's all kind of on a continuum of disease. People ask, well, what about e-cigarettes? That's got to be safer. Yeah, it probably is. We do see small airway disease in vapors, though. It tends to be more in the form of a combined, like, large airways disease with small airways disease, like in asthma. And then some people can get constricted bronchiolitis. There tends to be a lot of diacetyl in the flavorings, so something to be mindful of. Okay, how do you diagnose RB? Technically, again, requires a lung biopsy, although that is usually not happening. Most of the time, we have a good clinical history, patient smokes a bunch, and then they have other things on CT scan like emphysema, bronchial wall thickening, and we can make a presumptive diagnosis. It is particularly easy to make that diagnosis if the patient quits smoking and gets better. So like, here's a patient who's had a CT on the left, they quit smoking, and then 2 years later, ground glass and some of the nodules are drastically better. So how do you treat it? There's really not a ton of data on this, but the data that's out there really suggests just leave them alone and get them to quit smoking. If you quit smoking, it can halt progression or even reverse disease in a third or more patients. This is typically not described, just RB, so not like a fibrotic lung disease, just respiratory bronchiolitis as a disease that is progressive and leads to horrible disease in patients. So if you find somebody who's referred to your clinic with RB, it's usually a good thing because they can remove the offending agent and they should get better. Please do not put these people on immune suppressants. The data that's out there for it actually suggests they'll do worse. Okay, so last slide. What else can I read about? There's lots of random things in this bronchiolitis sphere. There's this eosinophilic bronchiolitis thing. There's diffuse panbronchiolitis, which is predominantly seen in Asia, which we extrapolate a lot of our macrolide therapy from. And then there's this thing called diffuse aspiration bronchiolitis. It is exactly what it sounds like. The treatment is getting the patient a Nissen or completely rerouting their GI tract. Okay, my voice hung on the entire time. Thank you for listening to me.
All right, thank you very much, Sean. Next, we have Dr. Rosa Estrada Martin, and she will be talking about bronchiolitis and interstitial lung disease.
Thank you. I'm going to try to squeeze this in 15 minutes. I'm from Montgomery Medical School, the University of Texas at Houston. I don't have any disclosures. Obviously, as has been said before, we are going to talk about bronchiolitis with interstitial lung disease. That means the airways that are affected are 2 millimeters or less. Usually interstitial lung disease anyway have, there are diseases that are the small airways involved, but also the parenchyma. But we are going to talk about interstitial lung diseases that have a strong bronchiolar involvement. And we are going to do a review about hypersensitivity pneumonitis, respiratory bronchiolitis, interstitial lung disease, cough, and a little bit about deep neck. So we have reviewed a little bit about how to make the diagnosis, so how to suspect the disease. And the truth is the only way to suspect that this is a patient that comes with symptoms. Usually the symptoms are very similar in all of them. They have shortness of breath and cough for some time, usually weeks and months. And the diagnosis is suspected using CT, and there are direct findings and indirect findings. The direct findings usually are bronchial dilation, centrilobular nodules and trim bud. And in direct findings, there is mosaic attenuation in an inspiratory film and air trap in an expiratory film. The nodules I've described before is less than 3 millimeters, and 20% of the population can have a little bit of mosaic attenuation and be normal. What we are talking about is the centrilobular nodules that you can see in the middle. They don't affect the subpleural space or the lymphatic area. So hypersensitivity pneumonitis is an immune-mediated response in somebody who is susceptible and has been sensible or sensitized to an antigen. There are many antigens, could be organic or inorganic, as in the list. And the fun part about hypersensitivity pneumonitis is the name of every disease depends on the exposure. So whatever they're exposed, that's the name they get. Obviously, it affects the terminal bronchioles, the alveolar interstitium, and pathologically, they have usually what is called loosely or poorly formed granulomas. Usually, there are some persons that have IgG antibodies when they have been exposed to something, but not all of them will develop hypersensitivity pneumonitis. If you do a BAL on them, they may have increased lymphocytes, but they don't have necessarily the disease. So requires some genetic and host and environmental factors. And what always has been described is an antigen presentation, sensitization, and second hit. And there is an sensitization, pro-inflammatory environment, inflammation, and the stream in the other side, some fibrotic changes. And obviously there is a presenting cell. They cause some response related to personal factors, environmental factors, and that can be cause chronic non-fibrotic HP or fibrotic HP. So there is individual susceptibility. The part that is quite fun in hypersensitivity pneumonitis is there are like 1 million ways of classifying. So initially was divided as acute, subacute, and chronic. More recently was acute and chronic. Also has been classified using CT and non-fibrotic and fibrotic. And even the CT is classified in different way. But anyway, everything talks about the same thing. When it's acute hypersensitivity, is usually when the level of exposure is very high, the patient presents with flu-like symptoms, and usually it's very fast, in 4 to 12 hours after the exposure. This is quite important because it has implications for public health. In chronic cases, them is more insidious and also obvious, this low level of exposure for a long time, like happened with the breather's lung. And this is a very short table only to talk about the most commons that we see. There is the farmer's lung, the hot tub lung, the breather's lung, and the offensive lung. Classically, they have a CT like we have showed before, and they have a BAL with lymphocytosis. How much lymphocytosis? Lymphocytosis, some people will say more than 40%, some people say more than 50%. And remember, normal is up to 15. So there is a border of nobody lands. So they are classified also as acute, and radiologists can cluster 1 when they see in the CT that they have ground glass centrilobular micronodules, mosaic attenuation, and air trapping, what used to be called head cheese before, or 3-density pattern. That means they are ground glass and normal lung and air trapping in one cut. Or cluster 2, that is only the ones that have some fibrotic changes, reticulation, or honeycomb. And this is an example of in the far left is centrilobular nodules. In the middle is mosaic attenuation and inspiration. And the far right is air trapping during expiration. All these diseases usually present at 56 years of age. Obviously, older patients have a higher probability of fibrotic changes. There is no sex distribution, but it really depends on the job. That will make a big difference. In the United States, there is a little bit higher prevalence in women, And although it's a rare disease, probably it's underdiagnosed or under-recognized. It's less common, what always has been described that it's less common in smokers or ex-smokers, probably because of the decrease of the inflammatory response. However, in patients that develop chronic fibrotic HP, it's usually more common in smokers. There has been association with hypothyroidism, but nobody knows why. And anybody who has autoimmune serology obviously do worse. And we will talk only about two of the most common ones. One is the pigeon breeder's lung. That is recognized in 5 to 15% of all breeders. It's relatively common in places like Mexico, Turkey, or Europe, but they have a lot of attachment to birds. And also in the United States, the numbers have increased after Iraqi immigrants because they are also very attached to pigeons. And when you examine somebody, it's very important to know, or you talk to somebody, well, not only the history, but obviously in different geographic locations in the United States will increase the probability they will have a farmer's lung if they're in farmland, or the pigeon breeders that is a little bit more common in areas like we work. The acute HP is more common associated to fungal involvement or exposure, and half of the chronic HP has been reported in avian antigen exposure. 40 or 50% of the chronic HP is fibrotic. As we were saying, you can divide it non-fibrotic or fibrotic. Obviously, as expected, persons that have HP, they have increased mortality, and as we assume, and I think since we do pulmonary, we know very well that anybody who has fibrotic changes, independent of the reason, they have a higher mortality of anything. There is a genetic variation, and now it's more recognized related to telomere shortening. And I decided to take a mud shot of the felons, as you can see. So it's very common to have exposure to pigeons or parakeets, canaries, or other animals. But the other part that is important to recognize is it doesn't require direct exposure to the bird. And we will talk, like in this case, the feathers duvet lung, the persons that are exposed to pillows or duvets that have feathers and they are not aware of, they also can develop HP. There's a cross-reaction that's very common, and it's very important to know, even if the patient doesn't have birds anymore, if they live in the same place, if they still they are in the same environment, they still can continue having problems because it's almost impossible to remove everything from the environment. The other one we're going to talk very shortly is about farmer's lung that was described in the 30s. The most common is thermophilic actinomyces and fungi. As you know, when the weather changes and the humidity, the growth is quite significant, but anybody can be exposed not only because of silos, but greenhouses, compost, and maize corn. The humidifier lung that has been described in any place where it's humid with water, like air conditioners, humidifier water, or ventilator systems. The same thing is thermophilic actinomyces. And the hot water lung that is more commonly described in water aerosolized or hot tubs, and they have usually isolated mycobacterial infections, especially in NTM. And more recently, there is an entity that is called the instrument's lung. This sounds quite disturbing, actually. That is contamination with mold mold bacteria or mycobacteria for the wind instruments that are still have moist, and saxophone or trombone or horn bagpipes. So occupational exposure and hobbies are very important in diagnosis of hypersensitivity pneumonitis. Like I said before, acute HP is very important to know because it can be important for occupational exposures. The symptoms are not specific. And the physical exam you already aware. Pulmonary function test in this case can be normal in acute HP. The patients can have a restriction or restrictive pattern and decrease the LCO. Hypoxemia can be present. As we said before, the BAL, although can be normal, the one way to make the diagnosis is with a classic CT finding plus lymphocytosis in the BAL. The CD8 usually is elevated in contrast to sarcoidosis, that is the CD4, and they have usually what is classic foamy macrophages. And chronic HP is a little bit longer presentation, can be misdiagnosed as UIP. So a good history, many patients don't remember the exposures, but you need a good thoracic radiologist to help you to make the diagnosis. And the lymphocytosis is common. In acute HP, biopsy may not be necessary. Pathology usually shows cellular interstitial pneumonia, cellular bronchiolitis, a poorly or loose form granulomas, and some degree of organizing pneumonia. They can have some multinuclear Janssen cells. And in chronic HP, they have a little bit more fibrotic changes. And this is an example of a loosely formed granuloma. The management, obviously, ideally, if you are able to recognize the exposure, so they should be completely out of exposure, and if the environment where they are, like in birds, they're still exposed, that will be a big problem because the disease will progress. If it's not possible because of occupational reasons to avoid exposure, then a strong discussion about how to try to avoid, to do things to protect the employee from the agent. In acute HP, if they are out of exposure, usually self-limited. There are not too many studies about corticosteroids in acute HP. In chronic HP in patients, usually in patients that have been exposed to birds for more than 2 years, they will have changes that may be not reversible. The patients that have ground glass opacities obviously respond better to corticosteroids if they have more than 20% lymphocytes and they have cellular interstitial pneumonia. The patients that require lung transplantation, they do better than patients with IPF. Theoretically, the worsening prognosis is, as you know, fibrotic changes, if they are not able to avoid the exposure, and low FVC and DLCO. And this is an example of a patient with acute HP. They had rheumatoid arthritis. The BAL lymphocytosis was 68%. And you can see all the very diffuse nodules. That patient, after avoid exposure, cell-limited, everything resolved. The CT became normal. We didn't do anything else. This is an example of a patient with the HIV, with the BAL was more than 57%. As you can see, has some ground glass opacities in centrilobular diffuse. This was an inspiratory film. It's a little bit expiratory that is more obvious. This patient has a little bit of reticulation. And the same case. Sometimes we'll give you the appearance that they have cysts, but these are no cysts, really are areas of air trapping. And this is the MIP view. This is another example, a patient with breast cancer, 64%, as you can see, has areas of mosaic attenuation. That is more obvious here. In RB-ILD, I'm not going to spend too much time because it was discussed a little bit. This is affect, obviously, smokers. They have significant smoking history, usually more than 30 years. They are patients usually 40, 50 years of age. They can have a mixed pattern in the pulmonary function test. Like mentioned before, the biopsy of smokers usually can demonstrate respiratory bronchiolitis. Doesn't mean they have RB-ILD. They can have pigmented macrophages. And the most important part is the smoking cessation is the treatment. They sometimes require corticosteroids, but the clue is to stop smoking. This is an example of a 52-year-old up to 60-year pack smoking, and maybe difficult to see because of the lighting, but there are many small nodules, centrilobular nodules. And this is a little bit in the MIP, a little bit more obvious. We will talk about COP relatively fast. This is a disease that was described in the 80s, used to be called BOOP. And we like all these letters in pulmonary, that is quite interesting. The most important about COP, as the name said, is cryptogenic organizing pneumonia, so we have to be sure that we don't have any etiology of the organizing pneumonia. So if it's an infectious processes or medications or something else, cannot be called COP. The most important is they usually have flu-like symptoms that last for weeks. The presentation is usually subacute. There is no sex predilection. The pulmonary function test can be a mixed pattern. The obstructive pattern is usually associated to smokers or former smokers, but a significant percentage, a quarter, can have normal pulmonary function test. The CT is quite nice for us, maybe not for the patient, but it's nice because it has classic presentations in some persons. They usually have a patchy bilateral alveolar opacity. They can say they looks migrated. Can look like a mask-like. The classic sign is a reverse halo or atoll sign. There is a ground glass opacity with the resolution, partial resolution or complete resolution in the middle. But remember, the reverse halo can be present also in fungal infections or some GPA or tuberculosis or lymphoproliferative disorders. Biopsy will provide the diagnosis. And the pathology is very classic. They have this polypoid, fibromyxoid tissue that is inside the alveoli, and we'll see an example, and something that has been called Mason bodies. But they don't have any fibrosis, no honeycombing, no fibrotic, any type. Has been described 4 stages in pathology, and they usually resolve with corticosteroids. The most important part about the use of prednisone is cannot be stopped too soon. Too soon, how much is too soon? So many of these patients get treated for 6 months to a year. If that gets discontinued too fast, they can have a relapse. The dose, obviously no based on randomized control studies, can be 0.75 to 1 milligram per kilo, and then can be tapered in weeks. There is a recent article in the New England Journal that is quite nice with an example of a review about COP. And the presentations can be ground glass opacities. With some patients can have ill-defined pulmonary nodules, and the lower one in the right side is an example of a halo sign. And as you can see, the alveoli has this like polypoid fibromyxoid tissue that is like getting inside the alveoli. And the last part that I'm going to review is deep neck. That is a very uncommon disease, but very important not to miss. What has been described since the 70s is neuroendocrine cell hyperplasia. They affect the bronchi and the bronchiolar wall. They usually doesn't invade it. And they believe that is the precursor of carcinoid. If the area that is affected is less than 5 millimeters, it's called tumorlets. If it's more than 5 millimeters, they're called carcinoid. These patients can have peptides that can produce some bronchoconstriction and can be confused with asthma. They can come and have symptoms that look like asthma, but they really don't have asthma at all. It's a little bit more common in women, 50 or 60 decade of life. They can have normal PFTs or obstruction pattern. And the pulmonary nodules in the CT, they are very small or mosaic attenuation or air trapping. Diagnosis usually require BATs, but it's not necessary. And this is one of our patients that have as you can see, a pulmonary nodule in the right lower lobe, and had also some mosaic pattern. She had a biopsy, and what she had was, obviously the nodule was a carcinoid, but she also had a deep neck with the areas that you see there, there were tumorlets, and it's positive for synaptophysin. And these are a few examples of the same thing. If you can see, the panel in 8 has multiple small pulmonary nodules. They have a little bit of ground glass attenuation and a little bit of air trapping. And these are some recommended readings if you are interested. Thank you.
Okay, on towards our last speaker, we have Dr. Mohammed Adrish, who will be talking on bronchiolitis and large airway disorders.
Thank you for staying this long. I'm the last person standing between you and your dinner, so I'll try to make it quick. And thanks to you, you guys made my job very easy because I can skip all the functional airway parts. So I'm going to be talking on bronchial. Oh, sorry, I opened the wrong slides. So I'll be discussing bronchiolitis, or more so bronchiolar disorder, bronchiolar involvement in the large airway disorders. I'm associate professor of pulmonary critical care at Baylor College of Medicine, and I don't have any disclosures that are pertinent to this presentation. So I'll be discussing small airway changes in patients with asthma and how it is associated with different phenotypes of asthma. There is some recent data on that I'll be presenting. And we'll also discuss small airway changes in various stages of COPD and how they are associated with emphysema. So we already mentioned bronchiolar involvement in the large airway diseases. Because I have very little time to discuss this, so I'll keep my talk focused on the asthma and COPD part. So you already seen this slide several times in the past 1 hour. So here is the large airway and the small airway, and this is the small airway is the part that is really that my talk will be focusing on, which is beyond the age generation. So what do we know about small airway in asthma? The earliest evidence for the small airway involvement was first reported by a necropsy review by Huber and Kessler, and they did this review back in 1922s. And what they found was these patients, after, when they looked at their lungs, they had increased bronchial and bronchiolar wall thickenings. They had hyperemia and cellular infiltration of the wall. They had increased granular activities, and there was numinal narrowing of mid and small bronchi and bronchioles. So it was recognized pretty early in our knowledge of asthma, almost like 100 years ago. So how prevalent is small airway disease in asthma? And this was a systemic review that was published a few years ago by Usmani, who has done a lot of work in small airway. And it looked at different parameters. So this is, on the top, there is a spirometry, plethysmography, then in the middle you have impulse oscillometry, and then bottom you have nitrogen washout and HRCT. And no matter what parameter you use, about 50 to 60% of the patients with asthma can have small airway disease present in them. What about association of small airways? What about what measures you use for small airway dysfunction? How do you diagnose it? And very eloquently, you mentioned different measures that we can use. Impulse oscillometry, spirometry, and body plethysmography. And what this study showed, which was done on cohort from Atlantis, which was 773 patients, that impulse oscillometry and spirometry tend to perform better when you're trying to establish presence of small airway disease in asthma. And this is another thing that the study showed, that it is present across all severities of asthma. And if we look at one of the parameters, which is decreased in FVC, which was one of the most sensitive parameters to detect small airway disease. And here is, you can see the patients with GINA 1, GINA 2, GINA 3, GINA 4, and GINA 5. And as you can see that the prevalence of small airway disease is pretty high as the asthma gets more severe. This is how the normal small airway looks like, but some important characteristics that the goblet cells are only sparsely present in small airways. MUC5AC is not usually seen in healthy small airways. Usually our healthy airways will have MUC5B, which is tasked with production of mucin. The extracellular matrix contains these 5 components, and the airway smooth muscles is mainly in the transverse orientation, and there is only very few spiral orientation down to membranous bronchioles. And as we go down to the terminal bronchioles, the airway smooth muscle kind of disappears. So what happens to small airway changes in asthma? There is increased epithelial cell turnover, and there is also hyperplasia of the goblet cell. Combined with the upregulation of MUC5AC, which is not seen in normal airway, there is mucus accumulation and plugging in the small airways. And that leads to alteration in the barrier function and impairment of the mucociliary function. It further leads to thickening of the basement membrane, and that what causes the stiffness of the airway. And also there is increased thickness of the airway smooth muscle wall, which is usually not present at that level. So what do we know about small airway dysfunction in different asthma phenotypes? So this was a study that was recently published a few months ago by Abdu and colleagues, and they looked at 197 adult patients with asthma, and they divided these patients into 4 phenotypes. They used cutoff of sputum eosinophils of 2%, less than 2% or more than 2%, or neutrophil cutoff of 50% or more than 50%. And they came up with these 4 phenotypes: eosinophilic mix, where they had both eosinophils and neutrophils; just the neutropenic, where the neutrophil was more than 50%, but sputum eosinophils was less than 2%; and the paucigranulocytic, where they had less than 2% sputum eosinophils and less than 50% neutrophils. And these are all the different measures that they did, and we already discussed them in detail, so I won't be describing them, but what they really saw is that the small airway disease was much more prevalent in patients who had eosinophilic and mixed profile compared to paucigranulocytic profile. And these are also the patients who may have, small airway dysfunction that is present silently. This was a study that was also published recently looking at the quantitative CT characteristics of the cluster phenotypes in severe asthma research program. They have about 450 patients. And I'm going to focus on just the DPM maps, which is looking at the small airway involvement. So right here on the yellow part is functional small airway disease. And you can see here, that's what the yellow color is in these files. So here we have looking at the different clusters. Cluster 1 is the minimal disease. Cluster 2 is mild disease. Cluster 3 is obese patient with asthma. Cluster 4 is severe asthma patient, and this is very severe irreversible asthma. So as you can see, as the patients get higher and higher, asthma, the CT also can pick up more and more respiratory small airway involvement in these patients. I'll switch gears to COPD. So what happens to small airways in COPD? As we know that there is a trigger to most of the patients that have COPD. Most common trigger for COPD is cigarette smoking. When the lung develops injury, it leads to airway remodeling, mucus plugging, and immune infiltration. And all these processes combined lead to exacerbation and bacterial colonization. And then it keeps on going on and on in a vicious cycle, which leads to small airway disease onset and progression, and eventually development of emphysema. So how prevalent is small airway disease in COPD? This is a study that looked at 112 patients. Most of these patients were female, about middle age, and they looked at gold stage patient, gold A, B, C, and gold D. So they had all stages of COPD. But they showed that 87% of the patient had some sign of small airway involvement. And here they're looking at R5 to R20, which is a commonly used parameter in the oscillometry. And you can see here that this is pretty significant. They also another interesting finding that they saw in the study was there was no association between the symptoms and the presence of small airway disease. Another important finding that we need to know for our patient, that many times these patients have small airway disease, but they have not manifested all the clinical features. And there are studies that are going on looking at maybe a potential of treating small airway disease early on in patients' development of large airway disease, so that you can minimize the progression of that disease later on. What about the small airway disease across various stages of COPD? This was a nice study by James Hogg, and he's done a lot of work in small airway disease. They looked at surgically resected lungs from 159 patients. We had patients from all different stages, and what they found was that progression of COPD was strongly associated with development of small airway disease. And I'm going to show some graphs here. So this is the graph that is looking at the FEV1 level and the severity of occlusion of inflammatory exudates. And as you can see here, as a patient is going higher and higher on the gold stage of COPD, these patients are developing more and more occlusion, as manifested here by drop in FEV1. Similarly, airway wall thickness is also, as you can see here, is significantly more thick as the FEV1 is dropping in these patients. This graph is looking at airway wall compartments. As you can see, there is more epithelium, there is increased smooth muscle, and there is increased formation of lymphoid tissue as the patient progresses through the gold stage. So again, this is a disease that kind of starts early and then kind of sticks with the patient until they progress to emphysema. And again, looking at inflammatory cells, you can see here they're kind of present throughout the stages, but as the patients go later stage of COPD, these inflammatory cells are much higher than what they are in the earlier stages. So what is the relationship between small airway disease and emphysema? Again, this is another study by the same group, by James Hogg. They looked at isolated lungs which were removed from the COPD patients who underwent lung transplantation and compared it with donor lungs, which were the control lung. What they did was they did multi-detector computer CT to compare the number of airways, measuring 2 to 2.5, which is what we use to look at the small airways. And they also used the micro CT to look at the extent of emphysema and the number of tremor bronchioles. And what they found was that as the patient progresses through the gold staging, the number of small airways actually start going down. And this is what links to development of emphysema. As the patient's developing emphysema, these smaller airways are the ones that are getting destroyed, and they're kind of diminishing in these patients. And this is, again, the same graph looking at the control versus patients who have developed emphysema. And as you can see here, that these airways number decreasing. There's another graph from the same study looking at the terminal bronchioles in control versus panlobular and centrilobular emphysema. And as you can see here, the number of terminal bronchioles are decreasing. And this is what manifests as expiratory flow limitation or resistance in these patients as the COPD progresses. So what are the therapeutic implications for having small airway disease? And this is my last slide as a disclosure so that you're pretty close to the dinner. So what are the therapeutic implications? So we really need to know that small airway disease exists in our patient, and it is quite prevalent, and especially in patients with certain phenotypes, it is pretty challenging in these patients. So there are certain drug factors that we need to remember. That small size particle works better in its delivery to the peripheral airways as compared to the inhaled agents that have large particle size. So if you're struggling with any of your patient and not getting enough drug delivery, that could be something that to consider. Similarly, speed and duration of aerosol spray is something to be considered. MDI tend to have higher flow rate as opposed to your DPIs or like a Respimat. They have lower flow rate, and patients who have lower flow rate tend to get more drug in the peripheral airways, because when you are giving these patients with a higher flow rate, a lot of the drug just goes to the back of the throat and sticks there, and very little amount of drug reaches their lung. Also, about the inhaler delivery efficiency, and as you know that from Respimat, there's very small droplet, they have very low velocity, so sometimes you may find a patient with COPD who may do better with the Respimat as opposed to just powder form of Spiriva. You also need to consider patient factors. What is their breathing pattern? What is the flow rate that they can achieve? There are studies that have shown that patients, if they're using DPI, they need to maintain at least 30 liters from all the way up to 60 liters per minute to get the drug into their peripheral airways. Also, how is their inhaler technique? Can they get the drug enough to their peripheral airways? And what about the disease severity? If the patient cannot generate enough peak inspiratory flow rate, will they be able to get the drug all the way down to the peripheral lungs? So what are our take-home messages? Small airway disease is common in patients with asthma and COPD. Patients who have eosinophilic or mixed granulocytic asthma, they tend to have increased distal airflow obstruction, and they also have increased small airway resistance, something to know. There's also evidence supporting the disappearance and narrowing of the small conducting airways before the onset of emphysema, and this is what explains development of increased peripheral resistance in these patients. And when we're talking about medication in our patient, we need to consider patient factors as well as drug factors to make sure that the drug is reaching where it's supposed to function the most. With that, thank you so much for listening.
Thank you very much. If there are any questions, we can take them, but I know it is getting late.
How do you use that in the adult population? And there's a data for that. And when have you used immunosuppressant therapy in bronchiolitis for your patients?
I'm guessing this is mostly geared toward me. I will say anecdotally, I've only biopsied a few people with pretty normal looking lungs. out of concern for constrictive bronchiolitis, and both times chose correctly. That's what they ended up having. Usually there's something. Like it's rare that somebody has just pure dyspnea without some objective finding. So the example I gave of a normal CT scan in the soldiers returning from Iraq and Afghanistan, they had abnormal CPETs, for example. Like they were not reaching VO2 max and stuff. So there's usually some other hint. I can't think off the top of my head what my two patients, what there was. Like there was something that seemed like maybe there was like idiopathic hypoxemia. Like that sometimes happens, but it is rare. So it is rare. To your second question about using some of these other agents like Symbicort, azithromycin, I use them very liberally. Like I'd say most people with some form of primary bronchiolitis in my clinic, I prescribe FAM therapy. So what you're describing is FAM therapy of azithromycin, montelukast, and fluticasone. The number of people that it works with is very rare. Like it is not common. I would say of that combination, the people that tend to have benefit with the most with the azithromycin, but that's really hit or miss. That's anecdotal. And then third, how often do I immune suppress? Probably like 50-50. It really comes down to like what I see on the biopsy. I put a lot of stock on what the biopsy shows. So if the biopsy is showing pretty inflammatory material, then I'll give it a whirl. And then some people are desperate, even though they're scarred, give it a whirl. But I usually set like a time point. Like we're going to try this for 3 months. We're going to bring you back in for another set of PFTs, walk the whole thing. And if there is no change, then we're stopping it because I'm not convinced it's going to do much. That's my practical approach to it. I don't have much literature to guide that practice. Do those answer your questions? Okay.
I just wanted to add, bronchoscopy with transbronchial biopsies typically have a really low yield, but there is some recent data, and that is a 25-patient series from Italy where they had cryobiopsy where they were able to make a diagnosis, but this is again a retrospective case series. Over since 2011 through to 2020, around 25 patients, they were able to make a diagnosis with constrictive bronchiolitis based on cryobiopsies.
Can bronchiolitis present as an unexplained hypoxia? Like, have you had any patients?
Oh yeah. I've definitely had patients with unexplained hypoxemia. Yeah, like I've had a handful of people with normal DLCOs, and it's just like this is unexplained. The people that we've gone looking for it in have something that really pushes us to go biopsy. So, like they have a connective tissue disease or something. Well, that gets messy because it's like how much CPETs are we doing during the pandemic, and like who can read the CPETs? Ideally, yes. Not super hypoxic. And to be fair, I'm always hurting a little bit because I practice at altitude, so we frequently have some borderline hypoxic patients with very minimal lung disease. So it ends up being a little bit easier for me to catch that hypoxemia.
Any other questions?
Thank you all for great presentations. The pathophysiology, like whether it's smoking induced or like exposure or the preference of the pathology to affect the smaller or terminal versus the upper, even though it's the same pathway for whatever organism or airway disease, is there anything like, is it like the extent of the disease cells, or it's more specific preference to sit in terminal bronchioles rather than the upper, or what is your overall thinking of the pathophysiology?
So basically, with regards to the pathophysiology, I think it is really related to the size of the airways. And the more down it is, for example, if it is the particles get smaller and they could get lodged there, or same thing as far as infections as well. The area to get affected because of the size and get impacted or get stuck is probably highest once you get to that point. Now, why does it present with infection with some and why it presents with not in others? It's probably several genetic reasons, and I'm not entirely sure if there is any study to say why some do, and it is most likely the genetic makeup or the other environmental factors which could play together in order to cause this. And each different pathologies are also different, as in some are constrictive, as we said, and some are involving the bronchioles. There are most of the viral infections typically present as an infectious bronchiolitis where it is more of a proliferative bronchiolitis. However, and the constrictive bronchiolitis is the remnant or of some viruses, and that is a very less likely cause, but it can cause. And it is of all the viruses, there are a few viruses only present with constrictive bronchiolitis, and that may be that may be secondary to the virus plus the genetics plus the environment. But generally speaking, more viral infections typically, if you see on a CT, would be as more like a tree in bird opacities. That is an immunocompromised, or in, as we said, in children, and that tends to be bronchioles with inflammation distal to it and more of a proliferative bronchiolitis as far as pathology.
Same applies for asthma and COPD, like, if it's the same airways, why would it be, but probably it's just the normal consequences of natural,
Right.
the disease.
Right, so again, with the toxin injury, like you ask about the smoking, the smoke reaches everywhere.
Yeah.
And it's probably, if you're reaching an airway where you can, cause just a little bit damage and completely occlude it, you're gonna have a lot more consequences than, maybe occlude, maybe cause some inflammation in a larger airway where you wouldn't be able to kind of make a big impact on the symptoms. So that's why, when patients with COPD develop small airway disease, the kind of, you see it in a lot of patients, kind of pretty prevalent there. Same thing with asthma, because the pathophysiological changes are happening in all airways, and as I showed in the data, it's kind of, up to 70 to 80% of the patients have small airway involvement. It just happens that because a lot of the small airway disease is kind of silent, we pick these patients pretty late. By the time they come to us, they had either an exacerbation or they had already progressed, to a more of like a central airway obstruction, of some sort. And that's when we kind of figure out, oh, maybe that's just the central airway obstruction, and we kind of don't see that maybe it originated back there in the small airway and kind of progressed.